Okay, so this next panel, as we're herding everybody together, is to further explore some of the opportunities in surgical training and surgical education. We have a really awesome on-stage demo that we're about to see. And we're going to hear from Justin Barad, who's going to do a knee surgery for us right here on the stage. You don't want to miss that. It's pretty fantastic. And then we're going to hear from Modi Avasar and Randy Osborne about a couple other opportunities in surgical training and surgical education. Take it away.
Well, thanks, and this is going to be exciting. You know, live surgery and no fear of complications, right? This is going to be great. So I really like to have everyone introduce themselves really shortly, and then we'll after that jump to the presentations. Is that right? Great. So, doctor, you want to go first?
Hi, my name is Justin Barad. I am a pediatric orthopedic surgeon and the founder and CEO of OSO VR.
Hi, Moti Avasar, CEO and co-founder of Surgical Theater.
Randy Osborne, the president, CEO, and co-founder of BioFlight VR.
Great. Well, so this is exciting because we're going to actually not just hear about the platforms. We're going to see some of it in action. So it'll be fun. All right. Want to take it on? Beautiful.
All right, everyone, pray to the live demo gods for me. Thank you. Yeah, louder, louder. I can't hear you. There we go. Yeah, it's a little food coma. I can get you out of it. Just to give you a little bit of background before we jump in. So before I got into medicine, I actually was dedicated to becoming a game developer. So I've been coding my entire life. I have a game credit with Activision. When I was nearing the end of high school, there was some illness in my family. I became interested in how to use software and technology to help people. And then a mentor once told me, if you want to invent something, the best way is to understand the problem, like a lot of people have been saying earlier. And so the best way to understand problems in medicine is to be a physician on the front line. So I chose to go to medical school and become an orthopedic surgeon. And there, during my training, I saw one of the biggest problems facing healthcare today. So you've heard a lot about see one, do one, teach one. And that's formed the foundation of medical training for maybe over a century. The concept was originally produced by William Halsted, and it hasn't changed too much from the original conception, in which it's an apprenticeship model, and we follow other people around for a few years and then are let off into the wild. And while this worked for a time, the data now is very troubling. At the end of around a 5 to 6 year residency program, from the general surgery literature, 30.7% of residents are still unable to operate independently. So that's almost a third. Furthermore, the number of residents that we can train is effectively capped by the Balanced Budget Act of 1997. So we're looking at a surgeon shortage of around 50,000 within a few decades. So it was with this knowledge that VR had its renaissance, and I have this background in game development, so I decided to do something about the problem that I was experiencing. And I co-founded OSO VR with a fellow professional game developer. And our mission is to improve patient outcomes through increased efficiencies, increase the adoption of new medical technologies, and also democratize access to surgical education around the world. So today I'm going to be showing you a brief clip from some content that we partially produced with the help of the U.S. Department of Education, where we were selected as the #1 VR simulation company in the country. I'll be doing part of a tibial shaft intramedullary nailing procedure. So let's see if we can get this to work. I'll kind of just be yelling from VR. Can you hear me? If I say pineapple, someone run up on stage.
Right after lunch.
You're looking at around 100 procedures before you perform something safely. Up until then, your complication rates are
Nice, nice. Well, that was great.
It's sterile confetti. It's a vancomycin confetti.
Well, good. That's beautiful. So, should we go to the next one, and then we have some time at the end to discuss? Great. Marty, you want to go next?
Okay. Hi. So I'm not going to use blood and so on, so I'm sorry. Surgical theater, as our logo and tagline says, we are allowing patient and surgeon to walk inside the pathology. This is an example of a brain. And the inception and the accent is Israeli. And the inception of the company is from the Israeli Air Force, where we allowed by flight simulator, thank you. Oh, that's a complicated one. We allowed pilots to pre-live the future, to fly in between mountains to see what they can see in tomorrow's mission based on satellite images, and more importantly, to see what the enemy can see and how to avoid the enemy. So when the Israeli Air Force career ended, surgical theater started, and we're doing the same thing. We're allowing patients and surgeons to walk inside the pathology. And you'll see in a short clip how this experience happened, but we're taking CT and MRI of the patient, creating a virtual reality 360 environment, and patient hold the surgeon hand for real, and they're walking inside the pathology, and the surgeon may tell to the patient, this is your tumor, turn around, this is the vessel, let's walk in between the vessel and the tumor, and they can understand the margins, they can understand what's behind, what's in front, what are the risks. And our partner that studied this experience with patients, such as the neighbors at UCLA and Stanford and NYU and Mount Sinai in New York, learned that by having this shared experience and a very informed consent, patients are more likely to stay in the hospital, 40% more likely. And it was done, of course, without our footprint in the study, non-conflict of interest, and multiple institutions, from private to academic, prove that this environment of 360 VR allow patients to understand more, therefore to stay in the hospital, and eventually to rank the hospital higher. The same machine, the same 360 VR model is then being applied to surgery planning and surgery navigation. And
Kobe, do you want to
short video.
play around with this? What do you think?
You're the only kid in your class that can say you were inside your brain.
I saw my brain.
Yeah, you did.
It's all inside of it.
Right there.
What it used to look like anyway.
I woke up one morning and I didn't feel good.
He was doing this really weird movement with his right arm and right leg.
We saw 3 different doctors at 3 different facilities. They diagnosed it a tic and felt comfortable saying, just monitor it overnight. It's Memorial Day weekend. You're not going to get a team here anyway to do any imaging. Follow up with your pediatrician Tuesday. He says, your son has a problem, and you just see this mass in his head about the size of a golf ball. Just at a loss for words.
He said, this is too advanced for Bakersfield. You have to go to UCLA.
I got a phone call by a neurologist in Kobe's hometown who wanted me to see him right away.
Dr. Falla diagnosed it as a cavernous malformation.
Where this malformation was sitting, right beside the thalamus, it was causing pressure and potential injury to the thalamus. That's why he was having that weakness on the right side.
When you get so much information at one time and it's your baby, you know, it's really hard to take in.
We're able to show what things look like in 3D, and it doesn't really take much of an anatomy lesson to explain what's going on.
Being able to see an image like that, it really helped us understand what was going on in Kobe's brain. It was easier than seeing a regular MRI image, which is just a flat plate.
Just black and white with a blurry spot.
It helped to visualize it. You just kind of got a better idea of what we were dealing with, and it made it a lot easier on me to know how it was going to go. I love you.
On the day of the surgery, we're walking away. He says to Jessica, "Don't go, Mommy." We're just like, oh my goodness. We just went around the corner and got it together as much as we could.
The surgery lasted about 7 hours. It took us many hours for us to very carefully remove this cavernous malformation from the most critical structures in the brain, very important arteries and veins that were quite stuck to it. It's the inside of the tumor, right here. Precision VR really allows us to rehearse this operation and find the path to this lesion in the brain that gives us the safest entry point, the shortest distance, and the least probability of causing any neurological damage. This really helped us take the guesswork out of surgery. Even though we were there for the first time, it didn't feel like it was the first time. Kobe's doing incredible.
You would never know that anything was ever a problem before.
I like this part a lot. After Dr. Fala took the thing out of my head, I feel better. Everything's back to normal. Thank you for helping me, Dr. Fala.
So I do have a couple more slides, but I think this is the message: how you connect patient and surgeon together to provide a better care, and that's what we strive to do.
Great. Thank you very much. That was awesome. Awesome. Randy, you want to go up?
A lot going on. All right. Do you start it or what? Okay. All right. Hi. So I'm just going to jump into a few of the different ways that we are using VR to train, teach, test medical students, doctors, surgeons, et cetera, at BioFly VR. We've been around for a little over 2 years. Early on, we were fortunate to be approached by Children's Hospital Los Angeles and Oculus for their VR for Good initiative to develop a couple of training modules for their doctors, Todd Chang and Josh Sherman. So we engaged with them, figured out what they wanted to have created, and they really wanted to simulate pediatric resuscitation situations that are high risk, low frequency. These are situations that don't happen enough to residents to get the experience appropriate to deal with the situation. So here's a brief clip I'm just going to kind of talk over a little bit while it plays out. The volume doesn't have to be that high. Let's start off with the main menu. We have varying degrees of distraction, difficulty you can choose, multiple scenarios. Enter your data so we can track your progress along the way. Grab your hands.
Doctor, this is a 1-year-old
EMT is kind of giving the lowdown on the situation. How is this patient found? From here, the resident should be kind of evaluating from the get-go what could possibly be wrong with this patient.
Doctor, I think the child's having a seizure.
Doctor, what do you want to do?
There's your assistance there. The mom, she's freaking out. Part of this is to add the psychological, I guess, impact. Some basic procedures you can do along the way. Check the pulse. That updates with haptic feedback in real time along with the patient. Check the breathing. Is there any abnormalities? More clues it would give them to make a proper diagnosis. We worked very closely with the doctors while we created this to ensure that the fidelity and the feedback given was appropriate for the residents to make the proper decisions. This is not a one-to-one hands-on situation like the amazing technology Justin has. This is more of a cognitive experience. This is how do I take the proper steps to make it through the scenario and save this particular patient in this scenario. So all the medications you can choose from. All the statistics update in real time along the way. Abbreviated version, you save the baby, everyone's happy, except that one nurse. see your results there. Quickly, basic information about the scenario. Quantitative feedback, what did you do along the way? What decisions did you literally make throughout the procedure? Qualitative, yeah, you made that decision, but why did you choose this medication? Was that a critical error? Was that a mild error? All that is important to the doctors so that they could evaluate what took place without having to look over every session of every student. They can go back and review it. A quote from Dr. Todd Chang, virtual reality opens doors and new methods of training and will complement existing methods for healthcare training, particularly in high-stakes, low-frequency events. And that's what we used VR for, and we thought it was an ideal use case for VR. Along the way, we began developing some 360 stereoscopic, multi-camera, multi-angle views of surgical procedures. Surgical video is nothing new. People do that all the time. We've added some informational overlays, some audio feedback from our surgeons going through the steps. But the one thing we found out about this was not only is the high-fidelity surgeon's view important for the students to learn, the surgeons really love the 360 view of the entire process, and we have a God's eye view hanging over the procedure as well. So anybody new coming into their OR knows exactly how their OR should run. And they really like that because they're very specific about how their OR should run. Right now we're working with Dr. Ned Amendola, the head of sports medicine at Duke Orthopedics, as well as the president of the American Orthopedic Society for Sports Medicine. He has a different need for surgical training. He's tasked us with creating the ideal steps through a surgical procedure. So he wants his students to use VR to experience a common approach. We're doing the anterior approach to the shoulder. So step through this a little bit. This is some super ugly pre-alpha stuff, but we're playing around with the mechanisms to interact. Students will still be grabbing the proper tools, using the retractors, identifying anatomy along the way. All of this is kind of on rails in that the students are interacting with it and advancing the steps in a proper fashion. That's what he wants to see. All of that's happening at the Immersive Training Lab at Duke that we're creating with them as well. Imagine all the cool VR stuff that's going to go there. We're working with our hardware partners right now to finalize all that. Along with that will be a cohort study. 50% of the students will take traditional training. The other 50% will take the traditional training with unlimited access to the VR training lab, and Duke is writing up a paper on that and the efficacy of enhancing surgical training with VR. Then briefly, the CPR, this is something that we want to kind of tackle, gamifying it, making it more accessible to the masses. Some brief stats there, 350,000 out-of-hospital cardiac arrests occur in the United States, and nearly 2.3 million people take Red Cross first aid and CPR training each year. These are not just doctors, these are average citizens. And now many high schools are requiring CPR or at least offering CPR certification prior to education. So here's just a brief prototype of what this could look like.
Call 911.
So with this, we're trying to make it more engaging, a little more realistic in training, using any existing mannequin, and gamifying a bit, again, to make it a little more entertaining for a younger generation. One final quote from Todd Chang. People perform differently when in the real stressful context than in a lab or classroom. For example, we know that people tend to perform CPR faster in real life than during classroom certification training. And that's a problem we think we can help solve. Thank you.
Great. Thank you very much. And I can sit here. And so, well, like Brandon was saying, I'm going to be using my phone, getting emails from Brandon, getting questions from the audience, and this is really amazing, and really summarizes in a way, you know, how far we have gotten in regards to smartly using this available technology to improve how we connect, how we communicate, how we connect with patients, with providers, and how we train next generations. And I really think that to me it's pretty intuitive, and you're a pretty educated crowd, so you understand how intuitive this is. This has got to be good. We don't really have to convince anyone. I want to start again in the bad side of things, talking a little bit about, or asking a little bit. Well, what do you think the challenges are to having this be sort of standard? In the way we train students, we teach students, and we only have about 20 minutes or so or less. But so, what do you think?
I think it's not a technological problem at this point. That's the challenge. It's getting everyone to agree on how they're going to teach something. Whether you're talking about the particular, there are multiple ways to do the anterior approach that you're doing, or some of the surgeries we do, and this is one of the main problems in the world of surgery, is that everyone can kind of do whatever they want, and they all think it's the best way. So it makes measurement very difficult, and it's also going to make everyone agreeing upon a simulated sort of step-by-step approach to a particular procedure very hard. So you have to get all of these major governing bodies, like for us, the American Association of Hip and Knee Surgeons, the American Academy of Orthopedic Surgeons, the American Board of Orthopedic Surgery, and ACGME. Like, you have to get all these people to play nice together to agree on one set of a way to do a procedure, and also, what technology are we going to go with? I think a lot of people are recreating the wheel right now, and we all need to kind of work together to just move this forward a bit faster, so that people aren't duplicating effort. And in terms of, we all think that this works. In fact, we did a small pilot study, and we saw that students trained with OSO VR performed, based on the global rating scale, which is one of the most validated surgical scoring systems, about twice as well as non-VR trained individuals. So it was a shocking difference, and you could see that these first-year med students were operating at the level of a second or third-year resident. So we were all pretty blown away by that study.
Great, and that's really important, because again, we've talked about evidence. We kind of know it works and it should work and intuitively it does, but we need to get evidence, and that's what has been done. And in the case of, for example, also VR, that's fairly clear. And that was a question about that to you earlier. So about the challenges, briefly, what do you think, Mari?
So as an entrepreneur, every challenge is opportunity, and the first challenge is that you need to have the headset to really appreciate the experience, the 360. What VR really did, it really added a dimension to our life. We were living in flat, and now it's 360. And it's hard to convey. We can talk about it all day long, with accent, without accent. It's hard to convey. And this is part of the challenge. It's amazing once you have the headset, but then you need to have the headset. It's a physical element. So we do all kinds of projects, such as using phone and stream it. To every phone today can be used as a VR experience, and how do you distribute the experience to multiple users without the need of the VR headset? I think that's one of the challenges, and then the opportunities to do that technologically. And then everything that you said, I agree. It's an amazing technology, but what do you do with it, and how do you provide evidence it's really worth the investment? And the opportunity out there, and we've done very well with our partners to show that patients are more likely to stay, and so on. So those are the challenges and the opportunities.
Any quick words, Randy?
Just a brief kind of anecdote to Justin's point, as far as getting people to agree on the proper process. We flew up to see Dr. Gaba at Stanford, a master of simulation, and we were all my team was proud to show him the CHLA training room thing. He puts it on and kind of goes through it, and then he basically puts the thing down and goes, "That's crap. I would have immediately done this, this, and this. How can you tell me what I need to do?" And so there are ways we can mix up the variables and have different paths through it. It's a bit of a prototype, but it's to that point. It's getting everyone to agree that, or getting AI systems in place that would be more fluid and more realistic to the myriad problems that can show up in any procedure.
Yeah, just like we said before, like with any technology, I think in healthcare especially, I think that education is one of the paramount. You gotta let people know about this and preach about this and put the viewer on an administrator or on someone so that they can really get convinced, because the data is coming. Another thing I see as a challenge in a bit, which is temporary, though it's a temporary challenge, is the technology. The technology is great. We've done great from just 5-10 years ago to where we are now, and we got even mobile, AR core, AR kit, and it'll get better. It'll only get better, and you have to me as a surgeon, the training with a simulator, the thing is that it's not a substitute to regular training. It's just an addition. It's just a complement to the way we train to really use the time more efficiently and really become a better provider down the road. Because it's really in procedural stuff, being CPR, being orthopedic surgery, trauma surgery, anything is just about doing it over and over and over and getting experience and getting, aiming for perfection kind of thing. Right? So that's really important. And the technology, in the case of for example, also VR, I see, can't think of the name of the. There's a couple of platforms there where we have glove, VR, AR, glove sense. I think is the name of one of the technologies where you actually don't have controllers, but you actually have your hands kind of doing the actual procedure. I think that's, as a surgeon, that would be an important step. To try to get an instrument or your hands to place a chest tube or place a central line or intubate a patient, for example. I think that's something that is coming, and there's no stop to that. That's for sure the way things are going to evolve.
Yeah,
okay?
I agree. The peripherals and all the haptic feedback will be essential to doing the more one-on-one training.
Yeah.
I think our understanding of haptic feedback and its importance for simulation is still very early in our understanding. If you look at the data that's out there, haptics and force feedback have been around forever. And they've done a lot of studies with the Lap Mentor, and you're able to turn kind of the haptics on or off. And so they'll do these transfer validity studies where they look at the actual skill transfer that people receive from these simulators. And in the vast majority of these studies, the actual addition of haptics only added cost and maintenance issues. And in fact, they did some usability studies as well, where they'd randomize people between non-haptic or haptic simulators, and people didn't know which one they were using. And about 90% of people said that the non-haptic ones felt more realistic. So
Okay.
I think,
something. Thank you.
I started looking into this when I first came up with this concept. I thought that haptics is the #1 thing. I think every surgeon does. And so I wanted to try something that was like top-of-the-line haptics. So I just assumed the Da Vinci robot would blow my mind and I'd get a sense of where we needed to be. Yeah. And I used it for about 5 minutes. I turned to the rep. I said, "This is the best haptics I've ever felt in my life." And he looked at me and goes, "There's no haptics on this simulator."
Yeah.
Just to add, from flight simulators, they study, exist many years. So 70 to 80% of the immersion is from visual.
Yeah.
Haptic is
well, I think you can certainly trick the brain in any way you want. Having been a robotic surgeon for a number of years now, the visuals are so incredible in the Da Vinci robot that really, you see the deforming tissue and you feel that is actually you're feeling it, but you're not. You're separated by yards from the actual patient. So and again, it's all about data, evidence, but. Obviously, to me, I want to intuitively think that I want it as real as possible. With every sense exploited. With the technology, and I mean, time will tell. I think haptics are getting much better for sure, and the instruments is going to be more and more realistic, and up to a point where I think that in the next 5-10 years we're going to be laughing about this, sort of panels. But so I don't have any more questions from the audience. I think. That I can see here at least, and where do you think we are going? Well, what's the next 3 years? I don't want to go 10 years from now. How about 3 years from now? Where do you think we're going to be 3 years from now, Justin?
Well, I think the technology has crossed the threshold of where we can now achieve exponential skill transfer in a very scalable and affordable way. So we're already being used globally. And so at this point, the major challenge, I imagine, for you too, Randy, and other people in similar spaces is developing the content, is identifying areas where you can make the most impact and effectively train people. Like where does this meet a need in terms of training? And that is too complicated to learn through traditional methods. To give you an example, the medical device industry is struggling right now because every new product that they release is, in general, much more complex. Like the Da Vinci we were talking about, if you look at the learning curve data for that, you have to do 80 cases before you can just use it safely. Or something like anterior hip replacement, which has been around since the early 90s, late 80s. An expert surgeon who's done joint replacement his whole career has to do that procedure 100 times before he can do safely on a patient. So, I mean, these new techniques, minimally invasive techniques, new technologies like robotics and navigation are much, much more complicated than what came before. So there's an issue of access for patients to get these technologies, and when they're getting it, they might not be getting it safely. And so what's bottlenecking this high-value technology from getting to people is really this training problem.
Yeah.
So I think where is it going? It's pretty easy. Being in LA, I don't know how many of you read the book, but today Ready Player One comes out.
Yeah.
That's where it's going. Highly recommended to this forum to read the book, but also I hope I'm going to see the movie today. So where it's going, that in next year, this forum going to be very much like that, but everybody going to be in their house with their augmented reality and VR glasses. We're going to see each other, but not really be in the same location. And we're going to do things that required until now physical interaction, but the technology is going to take us further. And I think patients from Beijing will be able to check in Cedars-Sinai and have consultation inside their own brain virtually. And it's going to take limitation of time and space to sub-millimeter. I think that's where it's going, and Ready Player One is already there. It's real.
No, I agree.
If Hollywood can make a film, it's real.
Yeah. Randy?
Yeah. Yeah, so I think regardless of hardware, I think one of the big hurdles is giving access to people. How do they know, no matter what machine, computer, all that you have, how do the students gain access to that and take advantage of it? Which is why we're very interested in setting up the training lab at Duke. You know, I went to high school, middle school, high school in the late 80s. I went to computer labs. That was where I gained access to computers early on. I have a heavy engineering background as well, just because I got to play with computers. I feel that in the next 3 to 5 years even, that's still going to be very important. The high fidelity rigs will be very expensive. So getting the data points on how much square footage, how many computers, how many students can you run through there, all the metrics on that is going to be very important, and then be able to go into other universities and have that knowledge to expand and get the technology out there.
Yeah, I think another, I mean, this is a VR conference and we've had some AR in here, but we really need to look at what's happening holistically. Like what is the overall trend in the space? And, you know, I touched on it a little bit, but we have an aging population and we have kind of limiting sort of a bottlenecked faucet of providers. So how are you going to meet the needs of all these people that are going to need so much surgical and medical care? And so it's not just training, you know, it's going to have to interact with certain intraoperative, some of the stuff that Daniel Kraft was talking about, some of the AR applications and that you were talking about as well. And is there data from those applications that can be shared with our applications that can be synergistic in a way? And so I think, you know, this year's theme that David Ruhr was talking about is interoperability and really believing in working together and sharing platforms and not following down the path of EMRs and siloing yourself is the way that you're going to really solve a much bigger problem than just making an incremental step.
Yeah, no, that's super important. That's really, I was going to say that you know, being an older surgeon, I've been operating really, because I went to med school in Venezuela, you know, since the late 80s. I was in the operating room operating, and then I went to Ann Arbor, Michigan, and my surgery residency ended in 2001. And a few years after that is when we had the 80-hour week limit, and you know that's a real big problem that people don't realize. And this is a VR conference, but a lot of healthcare people here, and you know it's terrible how you see how you can be a very well-trained surgeon, you know, quote unquote, and you know how to do robotic, appendectomies. You know, you can, you can do a laparoscopic gallbladder removal, blindfolded. But how about when you can't, do that operation laparoscopically? You need to open up that patient, and you have residents surgeons actually who have trained for 5 years in a top place, and they have come out with, a couple of cholecystectomies, open cholecystectomies. How to deal with a complicated case that you need to then use traditional technologies when you have now a limited hours of training, and you need to master the new technologies. So I really see this type of platforms as really the holy grail of how do you train someone appropriately, taking into account, in the case of surgery or procedures, in general, how do you take into account, the traditional way of doing things and maybe the better way of doing things having a limited time. So it's really a demand problem. We're going to have so much more demand, and the offer of providers is only going to become worse. And we say, 50 or 150,000, it's going to be, I think the number I lately have read is usually it's 2030, the deficit of surgeons is going to be 150,000. But whatever the number is, it's only going to get worse, and I think we're falling short. We're going to have, especially in the more advanced countries, we're going to have a deficit not just of surgeons, but of surgeons that are trained to do not things that are super subspecialized. And I think these technologies can really, really play a big role in accommodating that.
And I just want to comment on one thing there. So what you said is absolutely true. The 80-hour work rule actually lost a year of training time. But how crazy is it that 80 hours a week is still not enough? So burnout is real. I was just talking with an R2, and he told me that he's going through a dark time, and that he heard that if you don't think about quitting during second year, you're not doing it right. Why is everyone having the same horrible experience? Why does it have to be this way? Can it be less than 80 hours and we can do a better job? So I feel like the status quo right now, well, yes, there are less hours and there's not enough time to train in the day. It's just because it's so inefficient. So I just, the resident burnout and fatigue and the number of fellowships people have to do now, it's just crazy what we're asking of these people. And then they have to find a job at the end of it. It's absolutely wacky.
Yeah.
It's 48 hours in Europe. The residents are still doing the same amount of procedures.
There you go.
Yeah. Yeah. You see, it's so there you go. So so any sort of final thoughts? We have about a minute and a half, or any pressing questions from the audience, if that's okay. I can open up to someone has a pressing question with this very fascinating Dr. Grants. So should patients have access to this technology? What do you guys think?
I think everybody should at some point. We have an issue in orthopedics where I think it was in 2014, 4% of orthopedic surgeons were female. And there were some studies that showed that if you exposed women to orthopedics earlier, either medical school or college, they're 75% more likely to apply and get in. And so there's this concept of career exploration with these training technologies, where you can actually explore careers that you didn't think you were capable of doing or would have never been exposed to otherwise. So I think that's very valuable, and I think for certain patients, it's really nice to have a deep understanding of the procedure you're about to go under. Now, some people we showed this to who did get the surgery and were very disturbed and had no idea what it consisted of and wish they could unsee their experience.
Yeah.
Maybe that's because of some of the blood we have in there. But so it's not for everyone from a patient's perspective, but it's certainly there's something there. So yeah, definitely worth looking into more.
And obviously certain, for example, surgical realities, it's obviously, it's a patient-centric, thing.
It is, but through the surgeons.
Yeah,
so
absolutely.
It should be facilitated and offered, because otherwise it's lost in translation to 360.
Enhances the communication, between surgeon and so I just want to kind of finalize in saying that just an anecdotal story from myself. Touch Surgery is a platform from the UK that is fantastic. They are in tablets and phones. But I remember when I first learned about Touch Surgery, step-by-step surgical a digital atlas, and I was playing with it, and I had a little patient. It was the middle of the night, and I had a 10-year-old patient who was really distressed, and they couldn't get an IV on him to put him down for me to do an appendectomy, and I gave him my phone, and he did his appendectomy, like in the pre-op area, and immediately calmed him down. He was 10, so he knew how to use my phone better than I did, and he did the step-by-step. So in some cases, but again, with the provider's guidance in certain specific, I think that the patients benefit tremendously from something like this. So I think that we're 000 now, we're right on time, and I want to thank you guys and really keep pressing for magnificent developments, okay? Thank you very much.